the routine clinic with headache, dizziness, chest pain associated with jaw pain, neck pain, and shoulder pain, and left-sided chest thorax pain. Her blood pressure on presentation was 200/120. In addition, she also had a supplementary presenting complaint of urinary incontinence and also oligomenorrhea. On the 30th of December, which was 3 days prior to presentation, she had acute back pain more towards the left side, which was described as tightening, tearing, stabbing, and prickling in nature. The intensity of the pain increased, and the following day she has developed jaw pain, neck pain, arm pain, and thorax pain towards the left side. These symptoms have also increased throughout the day. On the day prior to admission, she has developed left-sided chest pain, which was tightening, and she recalls that she has had a similar episode. She had a similar chest pain episode 1 year ago. She had taken painkillers for the pain, and the pain has not improved because, due to the painkillers, and she has delayed the treatment for the past 3 days because the children were not well. On the day of presentation, she has then developed headache, blurring of vision, slurred speech, and left-sided arm and leg weakness. In her chronic description of the history, on January 2018, she has had acute chest pain associated with sweating, and she has gone to the Kiribati hospital where her blood pressure was measured to be more than 200, as she recalls. She has been given a few intravenous drugs in the ETU, and she has had to be admitted for 5 days, and she recalls that she had several injections around the navel area. Thereafter, she has been discharged, and 1 week after discharge, she has developed an intractable headache associated with vomiting. For that, she has gotten admitted to the National Hospital of Sri Lanka, and she has undergone a CT scan, and she says that it was reported as normal. However, her blood pressure has been high, therefore she has been evaluated for secondary hypertension, and they have done a number of investigations that has, she describes some of those investigations as having to get off her medications for 2 weeks and then come to the hospital and become admitted for 2 days, and having to walk around the ward for a period of 2 hours and then giving a blood sample, and also taking her urine and pumping her urine for a period of 24 hours. And she has undergone several ultrasound scans of the abdomen. She has had to give urine fluid reports. She has undergone echocardiography, and she has undergone ECG testing and also treadmill testing. And she reports that all of these tests were, she said that all of those tests were normal. Thereafter, she has been put on regular clinic follow-up for her hypertension, and she was then recruited to a study where she was asked to take propranolol. So that is her history on hypertension. For the current presentation, the back pain was progressively worsening, and it was increasing in movement as well. And the chest pain was acute onset, progressively worsening, tightening, and it was...
That you would have described here itself, Ivan. Nothing, you are going back again to this. So when you present the current presentation, describe all those characteristics there. Forget it. Nothing just distracts you. You are discussing this, then you went and described that was perfect up to now. But whatever else you have to describe about the backache or the chest pain, you just start off by saying that and finish it off. Don't go back.
So, because she has secondary hypertension, I asked her questions related to...
Because she has secondary hypertension, can bear.
Because she has hypertension at such a young age, I decided to ask her specific questions to find a possible etiology.
Yeah.
For renal causes, she does not report having episodes of hematuria or frothiness in her urine, and she does not complain of symptoms.
Right, we'll come to that. Just give me a minute. Sorry. What did you put? Okay, now this patient has several problems. For the purpose of today's discussion, we'll focus on 2 problems, right? Okay. The background problem is what we're going to focus on first. So what is the background problem? This is a lady who is 44 years of age who has hypertension. Okay, so that's a background problem, hypertension. And it's quite a sort of a recent onset diagnosis also. 1 year vitarane. Yeah, so 1 year diagnosis. Now, when you have a patient with hypertension, the first thing that you need to focus on is what? Hypertension. The first thing you have to focus on is, was the diagnosis made in the proper way? Any patient that says I have high blood pressure, make sure that the diagnosis was made in the proper way. So these are various aspects that you need to look at. Like we discussed diabetes, same sort of structure comes in here also. So if any patient tells you hypertension, just ask them, how was it diagnosed? So how do you diagnose hypertension? Do you agree with the diagnosis in this patient? How do you diagnose hypertension? Most of the time it is a asymptomatic disease which is diagnosed on routine blood pressure measurement. Okay? Most of the time. And I would advise you to read on the proper technique of measuring blood pressure, right? That's very important, proper technique of measuring blood pressure. So it has, if it's a asymptomatic individual, you have to pay extra attention to the proper technique of measuring the blood pressure. This includes rest, calm environment, right? Proper measurement, measuring on both arms, and if the blood pressure is high, measuring on the second or maybe half an hour to 45 minutes later. All of those should be properly done. Okay. So just read, any guideline will give you the proper measurement technique. So I don't have to repeat that. Right. But of course, in this lady, there is no doubt about the diagnosis of hypertension, isn't it? Because of several reasons. One, the blood pressure on admission is very high, right? It's very high, far above the usual blood pressure. Also, she is presenting with, what did she present with? She is presenting with some acute organ damage, right? Probably acute coronary syndrome. Because Himal told us that she had probably enoxaparin injections around the umbilicus. So, the fact that she has a very high blood pressure, fact that she presented with acute end organ damage, there is no doubt about the hypertension diagnosis. Okay. But if it's an asymptomatic individual, you have to be very careful the way it was measured, the way it was confirmed. Right? That's why I want you to read up a little bit about it, the proper way. I have already given you some clues. The patient should be at rest, the blood pressure recording should be confirmed, right? Maybe 45 minutes later, right? And also maybe confirmed in a second visit in some cases, right? So it has to be a very careful procedure. But in this patient, you don't have to worry too much because she came with acute coronary syndrome, blood pressure is high. So you don't have to measure it on another occasion or do anything stupid like that. You would directly label her as hypertension. Okay, so that's very clear. So that's your first objective of assessment in a patient with hypertension. What is your second objective? Malinta, what do you think that we need to do next? Yeah, look for an etiology. Now, etiology assessment is important in some patients, right? What sort of patients? Young patients, especially patients less than 40 years of age. Now, even though this patient is 44, she is relatively young. So, all patients less than 40, you need to assess for etiology. What sort of other patients do we assess for etiology? First, yeah, if the first presentation is with acute end organ damage, or what we call this a hypertensive emergency. If they present with acute end organ damage, hypertensive emergency, they have to be investigated. So if the very first presentation is with acute end organ damage, In other words, hypertensive emergence, for us you have to assess the patient for a etiology. What sort of other instances? Okay, first presentation of hypertension in a very elderly patient, right, beyond the age of 60s. So they have been measuring their blood pressure perfectly normal up to then, but after about 60 years they are diagnosed to have hypertension. First presentation beyond 60 years. Tava? Yeah, so resistant hypertension, yes, you have to assess for etiology, but that's not at the initial point, but that's also important. So if you are treating a patient with hypertension not responding to medication, yes, you have to assess resistant hypertension. What is the definition of resistant hypertension? 3 antihypertensives at least at optimum doses with 1 diuretic. Right, the blood pressure is still not controlled, despite the patient being on 3 antihypertensives at maximum tolerable doses. So these sort of patients you have to investigate or evaluate for a secondary cause, right? Young patients with hypertension, patients presenting with hypertensive emergencies as the first presentation of hypertension, right? Then elderly patients, extremes of age with first presentation of hypertension, patients with resistant hypertension, okay? And also people who have extensive chronic end organ complications also, right, which are rapidly progressing, also need to be investigated. Rapidly progressing chronic end organ complications like left ventricular hypertrophy, ocular retinal changes, evagi. So in your long case, if you get this patient, she obviously qualifies for evaluation for a secondary cause, because she is young and she has presented with acute end organ damage and a sky high blood pressure, right? It's a hypertensive emergency. So you have to now look into the etiology, right? So then now in the history of focusing on the etiology. So what are the etiologies of hypertension or causes of secondary hypertension? I would say that renal is the commonest, the renal disease is the commonest, right? This might be acute or chronic, but renal disease is by far the commonest. So ask for symptoms of renal disease like body swelling, uremia, urine output abnormalities, or any diagnosis of renal disease anytime in their life. So edema, uremia, any renal problems diagnosed in the past. So again, direct questions now we are going to ask. Okay. Fine. What are the other causes of secondary hypertension? So she didn't have any renal problems in the past.
Endocrine.
Yeah, okay. So next would be endocrine. 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 There are several diseases that cause hypertension. This category is also called endocrine hypertension, sort of a special sort of subject in endocrinology. Yeah. So what is endocrine? What are the causes of endocrine hypertension? Pheochromocytoma, which is a adrenaline or noradrenaline secreting tumor in the adrenal gland. Commonly in the adrenal gland, it can occur in other places also, right? Pheochromocytoma. What is the typical history you get in a pheochromocytoma? There is a typical history. They get anxiety, palpitations, sweating, right? Fear of death, that sort of thing coming in episodes. it's not a persistent thing, it comes in episodes. So suddenly they get, these are called paroxysms, right? So sudden, unpredictable attacks of palpitations, sweating, anxiety. Sudden palpitations, sweating, anxiety, attacks, very intermittent. Intermittent attacks. Right? Sometimes during these episodes they get behavioral changes because all the sympathetic, it's overdrive, sympathetic overdrive. They can get aggressive, right, and have various problems during that period. So these are episodes. So pheochromocytoma. Tamonad, what are the other things, endocrine things that can cause hypertension? Cushing syndrome. Okay. Cushing syndrome is diagnosed on examination, not really in the history, right? Recent onset obesity is the thing, or weight gain is the clue. But it's a spot diagnosis. You can diagnose it just by looking at the patient. Right. Another disease in that pathway is Conn syndrome, which is a mineralocorticoid secreting tumor in the adrenal gland. Conn syndrome, aldosterone secreting tumor. Yeah, so what is the symptom that you get for that? Aldosterone excess causes hypokalemia. So these patients come with paralysis, right, and proximal muscle weakness. Hypokalemia causes paralysis and proximal muscle weakness, right, and it can actually cause, it can actually present absolutely like Guillain-Barré syndrome. We had a patient once, I think I was a house officer. Patient came, somebody has treated for Guillain-Barré, right, but in the private sector nobody has looked at a serum electrolyte, and we found the potassium was 2 or something like that, right. So when we went on investigating, and the patient had been treated for hypertension, resistant hypertension also. So he had, ultimately we found that he had Conn syndrome. So causes paralysis. So are the presentations, paralysis. Okay. Hari. What are other endocrine things that present with hyperthyroidism? Hyperthyroidism. There are some other rarer endocrine diseases that cause hypertension. I don't think you need to know a lot about them, right. There are various disorders in the corticosteroid pathway that can cause hypertension, right. Some of you might have heard of those. Apparent mineralocorticoid excess, and there are various rarer conditions. It's all within this pathway, right? This steroid pathway. Disorders in the steroid pathway. Not very important. Rare, very rare. Acromegaly also can cause hypertension sometimes, but that's again a rare thing. Okay. Right. So a lot of endocrine causes for hypertension. What are the other causes for hypertension? Yeah, cardiovascular, of which I think the important thing you need to remember is coarctation of the aorta. Coarctation of the aorta. How does that present? Sometimes it's missed in childhood and presents for the first time in adulthood with hypertension. What is the symptom that people might get? Yeah, intermittent claudication. Because there is narrowing of the aorta that supplies the lower half of the body, they might present with intermittent claudication, vascular claudication. Vascular claudication. Vascular claudication. What is other cardiovascular, vascular cause that causes hypertension? Takayasu's arthritis, especially in young females. Takayasu's arteritis. That's diagnosed mainly on examination, not on the history. They come with just non-specific features like fever and loss of appetite and nevage. Most of the signs are in the examination. They might have, these Takayasu people might have upper limb claudication because the disease is mainly affecting the aorta. It's a narrowing of the stenotic disease of the aorta due to vasculitis. We had once a patient who said that when she washes clothes and things like that, she gets arm pain, right? So that's called upper limb claudication, right? Because the stenosis is mainly related to the upper limb vessels, right? එකපාරක් හිටියා patient කෙනෙක් with Takayasu who said එයාට මේ මොනද රෙදි වනනකොට එහෙම pain, upper limb pain, and she had hypertension also. Right. What is the other important vascular disease that presents with hypertension? Renal artery stenosis. Renal artery stenosis. Renal artery stenosis presents with a typical syndrome which is called flash pulmonary edema. They suddenly come with massive elevations of the blood pressure and pulmonary edema, acute shortness of breath. Again, paroxysmal, unpredictable flashes called flash. Suddenly the patient is fine and then quickly develops full-blown pulmonary edema within minutes. Flash pulmonary edema and high blood pressures also. Flash pulmonary. Okay. There are a lot of other miscellaneous causes for hypertension, including drug ingestion, OCP being the famous culprit. OCP, oral contraceptive. Fine. So Himal, can you now tell us about your findings in that part of the assessment?
Before she presented in January 2018 with acute chest pain, she reports that she was having episodic headache associated with sweating, palpitations, angina, and she has been increasingly feeling irritable with her husband quarreling all the time, and this has also been associated with the oligomenorrhea. In 2017, she has noticed that her menstrual cycles were becoming irregular, and in 2018, she says that she only had 2 menses. Apart from that, she does not complain of any history suggestive of renal disease. She doesn't have proximal muscle weakness. She doesn't have any symptoms of snoring during sleep. She doesn't have any recent weight gain or striations in the skin. She doesn't have any symptoms suggestive of heat intolerance or loss of weight or gain of appetite. And she doesn't have any history suggestive of kidney stones. And she doesn't have a history suggestive of claudication of the legs. And she has not noticed any increase in the size of her hands or change in facial appearance. She has not been on any drugs suggestive of steroids or contraceptive pills.
Right. Okay, so there is a bit of history that is significant there. What is that? These headaches and this irritability, sweating. So might be that we are dealing with a pheochromocytoma, right? So that's something that we need to. Of course, these things might also be perimenopausal symptoms, right? But you have to always think of the pathological thing and exclude it, especially in this patient who has young onset hypertension, right? So the fact that she has this irritability and headaches and anxiety and things like that might mean that this hypertension is due to a pheochromocytoma. Okay. So we are now gone through the second element that you would assess a hypertensive patient by. First we have talked about confirming the diagnosis. Second we have talked about assessing the etiology. Third important thing is just getting a history to cover the chronic organ complications or the target organ damage, right? Target organ damage. In this patient, she has had probably acute coronary syndrome and ischemic heart disease, right? No strokes before whatever this point. So cerebrovascular disease, those things you have to ask. What are the main complications of hypertension? End-organ complications, brain, cardiac and renal. Eyes, of course, you can't get from the history. Okay. Right, so 3 things. The 4th thing is, in any hypertensive patient, is to assess their cardiovascular risk. We did that for diabetes also. In hypertension also you do the same. Assess their cardiovascular risk factors, other cardiovascular risk, and give them a sort of overall risk grading. So does she have diabetes, hypercholesterolemia? No, nothing. Right, so this 4-step assessment is what you do for any patient who has hypertension. Confirm the diagnosis, look for a secondary cause if indicated, look for end-organ complications and assess their cardiovascular risks. So that's what you do in the history as well as in the examination. Same 4 things you do in the examination also, right? Okay. Right. So what are the important things that you examine for, especially focusing on the secondary causes? In hypertension, what are the things that you need to examine for? Especially looking out for the secondary causes. We go system by system. Okay, general examination. You can make certain spot diagnoses, Cushing's, acromegaly, thyrotoxicosis, those sort of spot diagnoses you can make. Also remember, things like pheochromocytoma have certain associations. Tell me one. Pheochromocytoma is associated with neurofibromatosis. So you look for those features. Neurofibromatosis. Sorry? With neurofibromatosis? I think so, but it's not a very common association. So you can do a general assessment. Right. Then in the cardiovascular system, we talked about several things: Takayasu, coarctation and renal arteriostosis. So what do you look for? Pulse discrepancies. Pulse discrepancies can occur in coarctation of the aorta. Radio-radial delay, radio-femoral delay. In Takayasu, you find that these pulses are absent most of the time. Generally, upper limb pulses might be absent in Takayasu. So, any young female coming with hypertension, you have to look out for Takayasu. It's common in Asia, right? So, you have to look out for Takayasu. Looking at examining the pulses are very important. But in Takayasu, you get loss of pulses. Loss of pulses. Sorry. Coarctation of the aorta. Murmur is generally best heard in the back between the scapulae. It's an ejection systolic murmur, best heard in the back between the scapula. Takayasu, what do you get? Takayasu, rather uncommon. In Takayasu, you get bruise because there is narrowing, especially subclavian region, bruise. Takayasu can also involve the aortic valve and cause regurgitation of the aortic valve. Okay. So once we had a patient who had presented with aortic regurgitation and high blood pressure, young girl, and we initially thought it was endocarditis, but then it later turned out to be not so. Her ESR was high and no bruise. But then maybe we saw the patient every 3 months, apart about 6 months later she started to develop bruise and things, and we later diagnosed Takayasu. So Takayasu, bruise, vascular bruise are a thing that you look for. In renal artery stenosis, what do you look for? Renal artery bruise. Renal artery bruise. Abdomen. Abdomen related to hypertension, polycystic kidneys. Sometimes you will be surprised, patient has hypertension, undiagnosed, you will find polycystic kidneys. So important to examine the abdomen to look for polycystic kidneys. Okay, so these are the important systems to examine. Now, like in diabetes, make sure that you don't forget to look at the fundus in all hypertensive patients. Right. That's mainly for the organ damage. Organ damage. Fine. Then we go on to the investigations. A patient with young hypertension, possible secondary hypertension, you do investigations again for two things, two purposes. That's why the structure is important. Started off with 4 important things. First thing was confirmation of the diagnosis. Second thing was etiology. Third thing was end-organ damage. Fourth thing was cardiometabolic risk. So investigations also you do actually not for 2 but for 3 purposes. First purpose is to investigate the etiology. Second set of investigations you do for target organ damage. Third set of investigations you do for cardiovascular risk analysis. So that's the plan. So it goes to hypertension is easy because you have the same plan running throughout. You are looking for the same things. History, you are looking for the same things, examination, investigation. Right. Okay. What are the Isuri, you are in almost about to sleep. What are the investigations you do in this patient to evaluate for a secondary cause? First thing you do, what is our clinical diagnosis? Because of this young onset hypertension and this very high blood pressure, and these are episodes of irritability and anxiety and headaches and things like that, you think of pheochrome. So what is the investigation you do for pheochromocytoma? That's the first thing I would do specifically. Urinary metanephrine or plasma metanephrine, which is expensive but more sensitive and specific. VMA now is useless. We don't do that anymore. Pain. Ultrasound you won't see tumors. And I think I told you before also, endocrinology, you have to show that there is hormonal excess before doing imaging. Right. So we would arrange a urinary metanephrine or a plasma metanephrine as our priority in this patient. If of course that becomes negative, then you need to do a blanket screening for the other endocrine problems, especially the aldosterone renin ratio, ARR, is important. If it's a consider, we have discussed this before, they get what is the electrolyte imbalance, they get hypokalemia and metabolic alkalosis. We did a special discussion on that, I think about 2 weeks ago, right? Hypokalemia alkalosis combination. Right. If you think it's indicated thyroid function එහෙම කරන්න, but not in all patients. How do you assess for renal artery stenosis? You can get an idea from the ultrasound because one kidney will be small if it's unilateral. But the best way of looking at it is to do a angiogram, renal angio. If you are strongly suspecting it, you can also do a renal Doppler, which again might give you a clue. Renal Doppler shows the flow through the renal artery. That might give you a clue. But the best way of looking at it is doing an angiogram. Renal Doppler plus angio. So I think we should arrange those things. Maybe start off with the metanephrine. If that's negative, go with the aldosterone ratio, looking at the renal artery stenosis, say what we would look for. Alright, fine. You would also do a ESR, right? Look for Takayasu, basic investigations like that also. So I remind you that you have to know some of the causes of hypokalemia and hypertension, right? We discussed this, so revise that. Her potassium is normal. Another cause of hypertension that we commonly miss is obstructive sleep apnea, so be careful that you don't miss it, right? Obstructive sleep apnea. Maybe under respiratory causes or something, you write it down. OS. Right. So that's for etiology. What are the things you would do for organ damage? Basic investigations you do to assess organ damage. Sanduli, what are the basic investigations you do for organ damage? Renal function test, UFR. UFR might show a bit of proteinuria. Renal function tests. Ultrasound will give you an idea about the renal parenchyma. Cardiac angiogram. Basic things, ECG, echo. ECG and echo. If the patient has symptoms, angiogram, but otherwise ECG, echo. Okay, and also you would like to send the patient for a dilated proper eye exam and fundal photography to look at the changes in the retina. Right, so all of these investigations should be arranged. The last step of doing investigation, look for other cardiovascular comorbidities. So all of patients with hypertension should have a fasting blood sugar done and a cholesterol done. Things are normal, not normal. Cholesterol, hypercholesterolemia and fasting blood sugar. Okay, so it's important. So we have taken a patient with hypertension and discussed the basic principles of assessing a patient with hypertension, right? And it's a very nice patient because she has young hypertension, some symptoms of possible secondary cause, probably might even be a pheochromocytoma, so we need to look at that seriously and then look at that. So basically we have 4 points in hypertension. In the evaluation, so the evaluation includes history, examination and investigation. First of all, you should be sure about your diagnosis. But we see so many people who have been labeled with hypertension where the blood pressure has been measured incorrectly. In a busy clinic, patient is stressed out, you measure the blood pressure, start treatment on the first time. That's completely wrong, right? Here, of course, there is no doubt because the patient has very high blood pressures, hypertensive emergency, acute organ damage on presentation. The next thing you need to do is evaluate some patients for secondary causes. This patient definitely qualifies for that evaluation. Third thing you need to do is assess for end organ damage, maybe acute, maybe chronic. Fourth is to look for other cardiovascular risk factors. So the same thing is reflected in the examination and in the investigation. Same plan. All right. Okay, we talk about the management tomorrow because that thank you. But what we'll do is we'll look at a little bit of the patient's current presentation. Now, when I discussed this with some of you in the morning or yesterday, I think. So here, when a patient comes who has hypertension, comes with very severe backache, right? And maybe subsequently chest pain, ischemic symptoms. What is the first thing that you need to think of? Initially very severe backache, but then having sort of ischemic chest pain, jaw pain, all of that is ischemic. So what is the thing that you need to think of? Aortic dissection. So that's the thing that you need to think of. Right? Patient with hypertension, very high blood pressures, coming with acute onset backache, chest pain, ischemic type chest pain, aortic dissection should be considered. The top of your list. And remember, aortic dissection can sometimes present with neurological problems also because the dissection can go into the carotids also. Then it presents with neurological symptoms. Fine. So that's enough for today about hypertension. Hello. Hello. Oh. මොකක්ද මෙන්න හදන්නේ මේ ට්‍රැෆික් පොඩක් අඩු වෙනකන් හිටියේ. ට්‍රැෆික් පොඩක් අඩු වෙනකන් හිටියේ දැන් එන්න. මේ හොස්පිටල් එකේ. ඔව්. කොයිද අරගෙන එන්නේ නැද්ද? තේරුමක් නැහැ නේ කලින් ගියා කියලා ට්‍රැෆික් එකකට විතර රාජගිරියට යන තවට ට්‍රැෆික් පානදුරට යන තවට ට්‍රැෆික් පොඩ රෑම එකයි. Right. Any questions?
So when you're looking out, we are investigating for target organ damage, we investigate for brain damage, any brain damage?
Nah. If it's not symptomatic, no point in doing just CT කරලා වැඩක් නැහැ. Cerebral imaging එහෙම කරන්න ඕනේ නැහැ unless there is some neurological symptom. Right? You don't need to do that. මොකද සසංක? අපිටත් කියන්නකෝ වීඩියෝ කතාව. Saline infusion test is something you do for Conn syndrome. It's a rather advanced thing, don't worry about it. You might have seen people being admitted for that, but that's because we have an endocrine team. Okay, good question. When do you decide to ambulatory blood pressure monitoring? You have seen that ambulatory blood pressure. Eh? That's when you are not very sure whether the patient is having some white coat hypertension. White coat hypertension. Ideally speaking, you should be doing ambulatory in everybody because people might have white coat hypertension. White coat hypertension, when they go to a doctor, the blood pressure is high. But of course, it's not practical to do that because obviously ambulatory blood pressure monitoring is expensive. You need a special gadget to do it, right? So that's why we don't do it for everybody, but people who you strongly suspect that they have white coat hypertension, blood pressure only high when they come to a doctor, you do that. Also you do that in resistant hypertension and things like that to confirm.
So why does a white coat hypertension is it due to some
I don't know, might be, it must be. Sir, මොකද house coat hypertension ගැන කියනවද? කොහොමද? The opposite of this white coat is masked hypertension. Okay, when they come to a doctor, their blood pressure is normal, but otherwise it's high. ඒ වගේ අයගේ කරනවා ambulatory because if they have a target or say you have a patient normal blood pressure but LVH or something like that, then you again do the ambulatory to see if they have masked hypertension. Ambulatory blood pressure monitoring is now frequently being used. Right? It's being done. Yeah.
So are the patients kept in the ward during the test or?
මෙහෙමයි ambulatory blood pressure monitor ideally should be done with the patient put on the monitor sent home. We admit patients because if they vanish with the blood pressure monitor then finish, very expensive, right? So that's why we admit them, but admitting them is not ideal because they are in a ward stressed out, usually on the floor, anyway their blood pressures are high. Ideally it should be done with the patient home patient with the revala current. But if they break the machine or they vanish with the machine, then trouble. So that's why we admit. Hari. Right. Hari, yonder.
තාම රෙකෝඩ් වෙනවා. තාම රෙකෝඩ්. පානි. කුණාර පැකියු. සෝස්.